Good morning, everyone. Dr. Kassam asked me to introduce the speaker this morning because she is busy with another commitment. Now it is my pleasure to introduce Dr. Dilini Vethanayagam, who is the speaker for today's Medicine Ground Round. Dilini is a professor of medicine in the Division of Pulmonary Medicine. This is actually a new professor series. She is a scholar from the University of Alberta, and then had her training in internal medicine at the Queen's University, in respirology at the Western University of London, Ontario, followed by 2 years of research fellowship at the McMaster University, the Firestone Institute, a very prestigious institute. She has a special interest in rare disease, and she was actually instrumental to start the Center for Hemorrhagic Hereditary Telangiectasia here in Edmonton, and to establish a network of satellite clinics in Western Canada in coordination with the national network as well. She's been the PI for a prestigious grant from the NIH about this work. And she will be, she cares to say that she has 2 daughters. One of them is getting married this summer, and it is nice to hear all this news after so many months of darkness. And our seminar the title is Navigating Common and Rare Disorders in Canada's Health System. Welcome, Dilini. Please have your questions in the question and answer chat box. Thank you.
Thank you, Giovanni, and to Barbara, who assisted me in my promotion process. Today I will be talking to you about common and rare disorders in Canada's health system. My conflict of interest slide is noted below. I will be talking to you about how I got to this point in my career and the role of mentors at different stages of my journey along the way. I will also speak to you about asthma and Alberta's asthma management. What are the health services issues? On top of that, we will talk at the end about rare disorders management and navigating our system through an example of HHT, which I deal with. I graduated from the University of Alberta, as mentioned, in 1992. Medical class had 122 graduates, of which 71 went on to pursue a rotating internship and 46 family medicine. Both of those encompassed 96% of our class choosing to do further training in primary care prior to continuing on either in varied primary care settings or specialty training. I chose to go to do my rotating internship at Dalhousie University under the program director, Dr. Jean Bray, who's one of the early pioneers on gender equity issues in medicine. While there, I was introduced to vastly different healthcare services in the Atlantic provinces, working in different small communities along the way. I was also introduced to the potentials for infrastructure instability in a single payer system. And first introduced to e-records at the St. John Regional Hospital in the spring of 1993. That's almost 30 years ago. So I learned much more in that 1 year of internship, particularly the importance of primary care compared to the 4 years of medical school. As in that time, it wasn't necessarily a commonly emphasized issue. And as many of you know, who are listening today, the costs of care increased with more secondary, tertiary, and sometimes quaternary care services we delivered, both in the inpatient and the outpatient setting. Some of you may not be aware, though, that 40% of Albertans do not have appropriate primary care, and that impacts how we deliver care to those individuals. So during my time in training, I was mentored in different ways, including with EDI issues in Queen's University and Western, exposed through many mentors to gender equity challenges there. I was also blessed to have many male and female mentors introduce me, especially to respirologists at Queen's University, to the subspecialty of respirology and the career path in that direction. I was also introduced to physician health at Queen's University as the Professional Association of Interns and Residents Organization representative there, and soon after starting, had to deal with 2 resident deaths within a month, one from suicide, one a friend of mine I used to run with who developed viral myocarditis. But you can imagine the turmoil that caused for many residents in our different programs there, and having to coordinate different activities for people to explore the impact to them individually and as a group. Later, I was introduced to the possibility of doing an asthma research fellowship by a few mentors who challenged me to consider an academic career pathway. And that stimulated me to do a 2-year asthma research fellowship at McMaster University, at that time a CIP equivalent. So then there's a decision about moving back out west, vastly different than Southwest Ontario, or stay at McMaster. In the end, I decided to move back out west with my family, husband, and my 2 children. And I remember still Anne Fanning, who was one of the first people I met when I came back, in the way only she can say it. I'm glad that that division's getting more estrogen in it, because I guess I was first female in a long time to be part of the division, who's an academic clinician, and Paige Lacey, who's my faculty colleague, a PhD as well. So that was in the early years. I remember bringing that up to my then divisional director, Irvin Myers. And so this issue was rectified. Within a year or 2, we started to see more females coming into respirology, both in training and in practice. I was also blessed to have a forum. Once a year, we had a gathering stimulated by Anne Fanning, Lil Midzinski, and Donna Gilchrist, the 3 first females in the Department of Medicine. They had an annual social event, and that introduced me and helped me network with individuals from many different places, even in northern Alberta, as well as around Edmonton, and academic faculty. So both at McMaster and here in my first few years, 3 individuals who were significantly influential in my career path are my prior supervisor, Paul O'Byrne, Freddie Hargreave, who worked in parallel there at the Firestone Institute, and he just passed away a few years ago. But also Kieran Killian, who is a respiratory physiologist, and we used to have weekly sessions that he coordinated for all the respirology trainees in respiratory physiology and exercise physiology. And that also encompassed occasional visits from 2 very prominent respiratory and exercise physiologists, Maureen Campbell and Norman Jones, who left a lasting impression in my career. This is one output from my time there, with the different allergen challenge studies that I was part of. So when I moved here, I was able to get a grant about a year into my academic appointment with the assistance of Harry Leogoftis, looking at cognitive stress on students at the UFA campus. However, what I wasn't prepared for was, after hiring my first RA and in opening up the induced sputum lab, I had to deal with a human resources issue that many people could not help me with. It's called a general illness leave. So after a few months and having to close down the study and close down the lab, I turned to Bob Turner, who's my formal mentor, and he helped me navigate how to deal with this issue early in a career. And my then department chair, John Meddings, along with Bob, helped me to modify the impact in terms of my career, because a lot of the grant dollars had to go to some an individual, by no fault of her own, having to be on sick leave looking after an end-stage family member. So that taught me a lot in terms of grants and the stability of grant structures that could impact much of our career. I was also asked by Redwin Mockbell, one of our pulmonary research group members and chair at that time, to PI a fragrance challenge study with one of the companies in the south end of Edmonton called Toxcon, who work with the Research Institute for Fragrance Materials. And we developed a 4-way crossover study looking at common household fragrances, placebo-controlled, and opened up with dollars received from that study a beautiful challenge chamber that we still use, which was previously used primarily for storage for many years. However, during that process, I also had to learn a lot about clinical trials liability planning, as hiring a RA from the university side didn't necessarily have the same protection if there was an adverse outcome, serious adverse outcome from the trial, as opposed to an AHS hire. There's a lady named Berg Malin who's retired now, along with Richard Fedorak in his research role back then, who were instrumental in helping us navigate those policies. But this is an important issue for many individuals with fragrance sensitivity. And here's a picture of Redwin, who's also passed away now, sadly. Harry, Paige, Lisa, Dean, and Daryl Adamko, who were part of the core research group back then, and then us as clinicians, part of a broader research group, PRG. I also learned a lot about industry contracts and payments with the second study, as we actually lost about $100,000 despite contracts being in place that impacted future research in this area and other asthma-related research. So we delayed publication for a couple of years going through that with NACTRAC and the RSO, and eventually we published this important Sentinel study to look at fragrance sensitization or sensitivity in the Journal of Asthma in 2013. Most importantly, a common question asked, there was no evidence of airway inflammation in individuals subjected to normal concentrations of fragrances. However, throat symptoms as an irritant effect was much more prominent in fragrance challenges as opposed to placebo. On the clinical side, asthma, when I moved here, I was surprised to find that there were 10 asthma clinics in the region. And most had funded educators, except the University of Alberta Hospital, where the majority of respirologists and allergists were. I was also encouraged to look at development of an adolescent transitional clinic by Karina Majasic, a close friend and colleague in pediatric respirology. As asthma is, as you know, the commonest chronic disease of childhood. So the high needs patients who were moving into the adult world were looked after during an important time of transition to adult clinics. And career counseling is part of that. Lastly, asthma is the commonest cause of occupational lung disease. And this year with Sebastian Strobe, we're supervising a summer student looking at occupational asthma reporting policies amongst the different provinces and territories in Canada. If we don't report it, we don't capture the commonality of this issue. Interdisciplinary or multidisciplinary care has many forms, and based on funding and stability, can take many different pathways. This is one example of a lovely pharmacist who was involved with development of educational material, Chelsea Papage, that addressed an important issue that many individuals with asthma were not familiar with at that time, NSAID-sensitive asthma, which tends to be more common in severe asthma as opposed to milder disease. So going forward, we looked at how can we do this better here in Alberta. As well as northern BC, the territories, we were dealing with quite a few patients from those areas over the first few years, and this got better with more trainees going to work in those areas who actually trained here in Edmonton. Interdisciplinary care, as I mentioned, can have many different forms, working with the Faculty of Nursing, supervised a nurse practitioner her last year of training who continued to work in our clinic, coordinating care for many of her high-risk individuals. We arrange case conferences that include ENT, endocrinology, occupational health with Jerry Beach, psychiatry, along with respirology and allergy immunology. We often involve patient care managers like Darcy Kozitsky, who was our then ambulatory care manager, which was extremely useful, and involvement of primary care. It also taught me to look at reverse referrals for individuals who did not have appropriate primary care to reduce ED utilization and multiple subspecialty visits. So models of care we look at may be different in each province. When I moved here, as I said, it was different for a small population. So that initiated discussion to look at a Canadian severe asthma network, because if you don't treat mild asthma well, you go on to be severe. We reviewed different models of care both in Canada and with Sally Wenzel, the Severe Asthma Research Program in the US, as to what works and what doesn't. We developed some standardized clinical operating tools which have been shared in many settings, including not just clinicians, but research settings elsewhere. But what's the best overall setup for asthma in Alberta? As well, why is there still industry funding of healthcare professionals providing asthma care, especially to vulnerable populations, including inner city? How do we ensure the models of care we develop are appropriate for different vulnerable communities? First Nations communities, especially in remote areas of northern Alberta and Treaty 8, immigrants and refugees, inner city, Boyle-Macaulay pathways. We've done outreach visits to both. And how we actually look at as subspecialists to deliver care for a common issue can impact healthcare costs. So the Asthma Society of Canada asked myself and a colleague who was an early mentor, Malcolm King, to join a group of individuals to look at respiratory health awareness, community outreach and management models for First Nations, Inuit, and Métis communities in a pilot intervention. This has helped a lot with my understanding of Indigenous health, especially for asthma care on First Nations reserves. Ellen Toth, who's the AHS Aboriginal Health Lead, and Jill Conkin, who's part of the division, the now closed division of community engagement, but also working with Fort Chip as a primary care individual there, were very instrumental in enhancing my understanding of the different issues within First Nations communities, quite different than urban First Nations. Along with different individuals who are Indigenous themselves, Gloria Latondra, who's worked in different First Nation communities, Little Red River Cree Nations, and now with Tall Cree First Nations in Treaty 8. Keenan Williams, who's part of the Population and Public Health SCN, the Indigenous arm. Leah Bill with the Alberta First Nations Inuit Governance Council, and Malcolm King in his early days while he was still here. And I think all those individuals had a significant influence on me as I looked at delivery of respiratory care to this specific vulnerable population. I also, through working with different individuals, Ellen Toth, Chris Sarin with Indigenous Services Canada, then called FNIHB, we did a student project. Medical student reviewed the location of Indigenous communities in Alberta. And here, the most important thing is to look at the preponderance of Indigenous communities north of Edmonton, north of the Yellowhead. And that has an impact, especially in Treaty 8, of how we in Edmonton can improve care for different individuals. And Last week, I'm wearing the closest thing to orange I have. We sadly learned about the mass burial of 215 students in a residential school in Kamloops. And I'm just bringing that up because it has so much impact on what we do and how we do it. With the Truth and Reconciliation Committee, there were 94 calls to action, 7 of them on health. And how are we doing? How are we as each individual looking at this issue, working in Canada? And 2 of them in particular, I'll highlight here. What is the current state of Aboriginal health, especially in First Nations communities, and what's the impact of different government policies and residential schools for long-term impact? We also look at how we train Aboriginal healthcare professionals, and I think the University of Alberta does that fairly well compared to other medical schools in Canada. However, we can always do better. But also training and retaining those individuals within the communities is vastly important. So educational sessions, working with them, and telehealth has been a significant positive to improve that. We also need to provide cultural competency training for many healthcare professionals, and that's starting in Edmonton, not as robust as it is in Northern Alberta within AHS. How about refugee and immigrant health? So working with Maher Sakur, who's one of our Syrian neurologists, we were able to, with different individuals in the Faculty of Medicine and Dentistry, put together a series of short lectures with web access that's still up there on the faculty website to look at common clinical concerns for refugees coming in mass a few years ago with the Syrian refugee crisis. We have many different groups of refugees coming into Canada, and the first year or 2 can have a significant impact on their long-term health. So what I realized with a lot of asthma care is, what are the barriers? And the largest hurdle is right in front of us. It's not the disease alone, it's the healthcare system as well. What can we do to improve that? As well, complex lab services like pulmonary function labs, sleep labs, echo labs, how and where they're structured, hospital versus non-hospital labs, can impact how care is delivered. I also saw an escalating industry involvement in academia, and over a few years, with a lot of encouragement from a few different individuals, I spoke to initially our pulmonary research group on a topic that was dear to my heart at that time, industry and academia. And this was first presented in March 2017. 6 weeks later, the media announced the concerns with the pharmaceutical industry influencing individuals who were part of the Canadian Guidelines Committee, making recommendations on opioid guidelines. That included 4 physicians. So there are different boom and bust cycles in Alberta, and that affects sustainability modeling within healthcare as well as different aspects of our economy. There were times where you just go, what's next? And you feel like you're in a hole. And mentors at different stages can help you to pivot through those times. Sometimes those mentors are patients as well. And I remember a retired social worker who was referred to me for severe asthma, saying she spent most of her life going to different doctor's appointments. So shortly after, we worked with other members of the Department of Medicine, Adrian Wag and Sebastian Strobe, to introduce a seminar to look at how many doctors does it take to see a patient. And it's meant to be a discussion forum. That was important because whether it's a rare disease or a common disease, how we actually address ambulatory care services will impact our time, effort, and overall healthcare costs. We have many, many different subspecialty services within internal medicine alone. But often we may or may not look at the details of, does this patient have a primary care practitioner that they actually trust and go to? And how do we communicate with them? How do we involve them with long-term planning? So reverse referrals was very effective with some of my primary care colleagues for high-risk patients who did not have appropriate primary care setups. I actually recall one gentleman with COPD who moved from Winnipeg who introduced me to the term credit card medicine, as he was shocked that the family doctor he was going to had a credit card machine right in the counter, and a lot of the services were based on how much you could pay. He, after being referred to another individual, has hardly come to see specialty care for many years and is doing well. Clinical skills is an important part of what we do. And in the era of AI, machine learning, it may have been taking a second place over the last few years. However, through my work with Dr. Laurie Mariou, when we had the Gilbert Clinical Skills program in our medical school, we created a passport which has been since distributed in different settings to not just medicine, but nursing individuals, medical schools abroad, and also to First Nations communities, healthcare practitioners. We spoke about lab services, and I approached Dr. Guyot, who some of you may know from his long history of research and one of the people who coined evidence-based medicine. But he also did a lot of work with public versus private healthcare. And in 2013, the government in Alberta was proposing further privatization of health services. And you may remember a company called Sonic, who was going to contract out more of our lab services. It's an Australian-based company. So I asked him if he can talk broadly about funding and delivery of healthcare services. So in 2014, we presented the first of two seminars looking in the context of the Canadian health system, which underscores public administration of healthcare in most aspects, along with the 5 key principles noted here. And then the next year, we presented delivery of healthcare services. AHS is not public, it's private, not-for-profit. So lab services held within AHS has a different structure for a not-for-profit as opposed to for-profit external to the hospitals. Why does that matter? There are differences in different studies for public versus private hospitals, hemodialysis units, hospice units that have been shown to be different for the model of delivery. So that took me back to a project I'd done with the continuing learning office here in Christagara, that we had looked for about a year at administrative data to evaluate asthma overdiagnosis in this province. And after a year of back and forth meetings, we realized that we can't get the metrics we want to actually evaluate asthma at that level at a provincial capacity. And we published that in a local student journal called Spectrum with a couple undergraduate students. And it's still a challenge for PFT labs in this province. Accreditation works differently for some provinces versus others, and linking data for administrative database searches is limited compared to Ontario, where we have the Institute for Clinical Evaluative Sciences. So a lot of time and effort from individuals all across the province had to be shut down due to inconsistencies in how administrative data are captured in this province. I later went on to work with the Asthma Society of Canada to look at patient journey. How do we look at patients' experience in severe asthma care in different provinces? So this was published online and it's still on the Asthma Society website. And also locally worked with different members of the Faculty of Nursing here to look at self-management for individuals with severe asthma. Very different than regular asthma, those who are well aware of their disease, very much like CF patients. So it took us back to looking at asthma and COPD as two of a few different chronic disease conditions, where there is growing literature on ambulatory care sensitive conditions. So having a continuity of care model within primary care is vastly important. As I mentioned, 40% of Albertans do not have this model of care. This did not include evaluation of individuals on First Nations communities, but that has an impact on ED utilization, on specialty care visits, and hospitalizations. We're going to take a turn here, and hopefully at the end we'll talk about linkages of both common and rare disorders. So rare disorders as a group are more common, and some of you may have heard this statistic that 1 in 10 people have a rare disorder. But there are many varieties of rare disorders, and some have higher impacts to our health system than others. HHT, or hereditary hemorrhagic telangiectasia, is one that has two populations in particular that have high healthcare utilization. They can have strokes in two different fashions: embolic strokes from pulmonary AVMs, which create a right to left shunt, and hemorrhagic strokes from cerebral AVMs, both in children and adults. There's also a subgroup of severe HHT bleeders from both epistaxis as well as GI bleeding. They can have high utilization of IV clinics and medical outpatient units and high ED utilization. Dr. Laurie Lerat, who's retiring the end of this month, told me a few months ago, I still remember having to medevac a patient with HHT and severe bleeding, Dilini. And I had to convince many people why a STARS ambulance was needed for this individual. That just underscores the impact of nosebleeds in this population. So we had to develop a team locally to deal with this rare disorder. So when I came, I understood very early on how much involvement of diagnostic imaging services was required. And Richard Owen, who's pictured here, is the associate director. He's an interventional radiologist, and working with different neurointerventional radiologists along the way. Rob Ashford, and more recently, Jeremy Rempel, who moved here from Ontario. We also need a strong ENT rhinology group, echocardiology, stroke neurology, and within the Department of Medicine, hematology, gastroenterology, and hepatology in particular. Again, I knocked on Karina Majacic's door to ask her to help develop the pediatric team. And this is only a few of the clinical services that are required. Medical genetics has gone through many ups and downs, and changes in how lab services are delivered. And most importantly, again, having effective primary care. So using the model for asthma, I started giving reverse referrals for individuals who did not have comprehensive primary care, where feasible. That can lead to significant reduction in ED utilization and specialty visits unnecessarily. So 2 years ago, just prior to COVID, we published this article working with Alberta Health and the stroke group led by Tom Jerichothel to capture data of individuals presenting in any AHS facility, ED or hospitalized with strokes, and using rigorous methods and physician diagnostic codes, looking at HHT at a jurisdictional level of the province. We were the first jurisdiction in North America to establish rates for HHT, 1 in 3,800, much more common than expected. And as a comparator, hemophilia is 1 in 10,000. So that was one key with this publication. The other was noting that females were more apt to get diagnosed with HHD, even though it's an autosomal dominant disorder, for different reasons we can talk about later. And females were also at higher risk of stroke. We're not talking about just adults, remember. We're talking about children, pediatric strokes, and adults. So Tom has been an excellent mentor over the last few years and guide to the complex world of stroke care in this province. With HHT, as I mentioned, I'm part of an NIH collaborative. It's a multi-center clinical trial with publications still coming out. This is one of the early publications in Stroke Journal looking at hemorrhage rates from brain AVMs in individuals with HHT. It also taught me about collaborative authorship, which is very different in terms of how it's viewed in different universities. With the International HHT Foundation and the North American arm, we have quarterly meetings of the center directors. And for a couple of years, we were discussing how do we develop satellite clinics by health jurisdiction. And why that was important, I had to convince different individuals. But because of our single payer system, it works very differently compared to the US, which if you bring more patients into a hospital or ambulatory setting in a hospital, you get more money. That's not the case in Canada. So we were able to convince them of the importance of that, pointing out, for instance, things like provincial jurisdictions matter for many aspects of care delivery, molecular genetics. If you have a BC healthcare card, it's very different getting specific testing done for disease X or disease Y. And in Alberta, we have a very complicated process with the Genetic Resource Center. Depending on the disease, if we have to send patients out of province or out of country or their blood for testing, it can be months of back and forth dealing with that to prove that we need to do the test. The fiscal realities of healthcare delivery and sustainable modeling became very apparent. And slowly but surely, the North American Consortium is aware of the differences in the Canadian system as opposed to the US. And also having satellite centers helps with nurse coordinator, assisting with care coordination, and also building regional expertise. Both medical records and imaging records are not streamlined between provinces, and the crossover can be quite challenging. HHT individuals have numerous types of imaging modalities, and we have to follow them sequentially over time. So neuroimaging, pulmonary imaging, liver imaging, and retrieval can be very time-consuming. So 30 years later, the Canada Infoway is as yet not established. It'll be coming, and there's movement in the last few years. But Alberta Health Services is way ahead of the ball with NetCare, as well as now Connect Care coming into being. So here's our current structure of satellite clinics. Saskatoon, in BC, we have 3, Interior Health, Vancouver, Prince George. In northern BC is small satellite with one of our trainees who's working out of there, who's helping with a few patients from north of that mountain range, as they do not find it easy to travel to Vancouver. In Alberta, we have established with our initial satellite model a very strong clinic in Calgary. South Zone we're working on, and North Zone we're working on. Central Zone still is a challenge because of different individuals coming and going in terms of healthcare delivery. Not the patients, but different physicians, funding, and structure. So that's how our rare disease HHT center is structured. But we still get people from different places, and during COVID, I've had a couple referrals from the Yukon Territories, coordinating 3 to 5 day bookings for the multiple services that are required for individuals coming out of province can be a challenge at the best of times, but especially during COVID. And Iris initially, and now Anne-Marie, my MOAs, have been very helpful with assisting with this. Standardization of assessments is also important for rare disorders, probably more so than common diseases. So first is training up multiple subspecialty leads at each site, but also for accredited echo labs. This is an ongoing challenge in some areas because that is one of the keys to screening for pulmonary AVMs and the shunts that are created. They're different if it's an intrapulmonary shunt or intracardiac shunt, and which echo lab is used, how the study itself is done, has been greatly impacted positively by having echo leads like Jonathan Choi locally, who also happens to be one of my med school classmates. We developed a forum for provincial imaging case conferences that's held every 2 or 3 months. On top of that, genetics case conferences when needed, obstetrical case conferences for people with especially known HHT, father or mother. Often these individuals are going through high-risk obstetrics, and perinatology, obstetrical medicine, etc. are very involved. We evaluated the costs of blood transfusions as opposed to intraoperative laser costs in a business report to help access OR services for laser in the province, as opposed to sending more people to Vancouver for laser surgery. So that's been established for about 6 years now, as well as more imaging standards. And one thing over this past year and a half is establishing a province-wide standard for cerebral AVMs with how the process is done, whether you're in southern Alberta, central zone, or here in Edmonton. And with COVID, that has helped immensely with reducing travel for patients. That's now been adopted in Saskatchewan as well. CT chest, many more nuances. It's in development, but imaging standards for this are absolutely needed. Working with my partner in Calgary, Charlene Fell, and different radiologists, we are working towards getting that in place. This is one example from earlier this week. We have, as I mentioned, imaging case conferences, and we're not just talking about chest imaging. This is a patient with a spinal AVM that had a prior leak, and we're looking at long-term management issues. Multidisciplinary in a whole new way. A lot of that experience taught me about the importance of being involved with the solutions, and clinical care alone is not the sole role of academic medicine, and so I was given the opportunity to be part of General Faculties Council, which I am still part of, and the UFA Medical Staff Society executive. Dilini asked me to join the AMA Respiratory Section executive for a few years. I'm not on that anymore, but it helped push forward a couple different projects in regards to respiratory services. And in July of this past year, I was elected as a GFC rep for the Board of Governors. Now, that in particular has had a significant impact to me to be part of the UAT, University of Alberta for Tomorrow, academic restructuring and the service excellence transformation, which has a huge impact on our faculty, the largest faculty on campus by far. So are there still challenges? Absolutely. So I talked about the NIH Rare Disorders Consortium. So yes, I am the center PI, and the REB continues to be open here at the University of Alberta. We have manuscripts ongoing, but cycles 2 and 3 are unfunded locally, and I've been asked by a few people why. It's because of cost neutrality based on organizational structure, and that is very different than a cost incurrence by having contracts signed off, who deals with accounts management. And I'm hoping that with service excellence transformation that will improve. In summary, I talked at the beginning about myself, along with many others in my class, participating in a rotating internship, which is not in existence anymore in Canada. However, practicing as generalists is something we all need to look at, whether you're in primary care or specialists. In today's economic situation, it's even more important. And there have been discussions within the primary care world about reintroducing a common PGY 1 year. And one of our own, Daniel Shafran, had published this. He shared it with me on rotating internships while at U of T. So whether you're in primary care or specialty practice, looking at the bigger question of how we deliver care, working with our primary care colleagues, will be important during these times of fiscal reality in Alberta. Our boom and bust society makes it even more so. So with that, I'll close off to say thank you to the many more mentors, as well as patients and patient groups, and this is given with permission of one of our champion patient group leads, who has raised lots and lots of dollars for student projects and awareness initiatives, Dilini. And June is HHT month, and it's Indigenous month, so a lot happening this month, despite COVID, and despite all the restrictions and in-person visits and meetings, we can still do things virtually. And with that, I'll close and also say thank you to my family. And as I mentioned and Giovanni noted, we have the wedding of my older daughter, Tiana, this summer. And yeah, looking forward to that in July, with or without COVID. Thank you.
Thank you, Dilini. I think we have a question from Dr. Turner, who's a panelist, so I can speak of the microphone.
Hi, Dilini, and I want to congratulate you on really an excellent survey of your career and of your ongoing contributions to the whole field of medicine in Alberta. I'm really proud to have played a very, very small part in your development. And my question actually is about the last part of your talk, and that's on the HHT. I had a fair bit of involvement with HHT patients over the years, and one of the things that we sort of chanced into was that I treated a patient with who had life-threatening gastrointestinal bleeding from HHT, and I actually forget what the connection was, but I thought that we should try interferon in that patient. And in fact, the interferon treatment, this was back in the 90s. The interferon treatment worked for this patient, and his gastric lesions regressed, and he lived for several more years after that. Interferon doesn't work for everybody, and I think it's related to the genetics of HHT. And I'm just wondering where we're at with the genetics and treatment modalities for HHT.
So thank you. And first of all, thanks, Bob. You've been a mentor in many areas, not just my formal mentor with the general illness, but Lori Laratte, yourself, and some of the senior hematologists with HHT and that bleeding population. It's huge, and they're in and out of Emerge all the time, the subgroup. There are other therapies that have been utilized, which I didn't go into today, for bleeding. One, we were able to challenge the Alberta government with the use of Avastin or bevacizumab. It's expensive, it's a biologic, but if you look at the literature back then, 2008, 2009, we used an N of 1 case to challenge the use of bevacizumab. And after that, we've been able to establish use for a subgroup of HHT bleeders who had severe GI bleeding. It's still a bit harder to get for epistaxis, but that alone has helped so many people lead a much more normal life. There's discussions recently about should we use other therapies like sirolimus. Interferon's not used as much anymore for this population, but good point. But I think a bigger thing, so it's a rare of a rare. It was already in use, this one drug, for colon cancer patients in the province, so that made it a little easier. But at the same time we were going through this, there were many patients in BC who were bleeding, who didn't have access to the same drug. I pulled a couple slides just for time, but there's a website, if anyone's interested, called $1 Million Meds, and there's lovely, lovely drugs in development that have a huge impact on a small group of individuals. But if it's overused, it can be very costly to the healthcare system. So apart from bevacizumab, there's some newer treatments coming that'll be more effective, not just for the GI bleeding, but for epistaxis management. BC, 5 years later, with my colleague Pierce Wilcox in Vancouver, we spoke to the Ministry of Health there, wrote letters, and established funding for bevacizumab for that province, using Alberta as an example. And right now we're doing the same for Saskatchewan. So each province is unique and different. Alberta actually has, in this area, fairly good provincial government funded strategies for expensive therapies. It still has a long way to go, but it's also how drugs, expensive drugs, are incorporated within healthcare structures. So if we don't have primary care, or we don't have specialty care, continuity of care models, introducing drugs that can have no expiry date, no end date, can have an impact on our single payer system unless that changes. So interferon, no. Bevacizumab, yes, at this time, and it's very effective for the majority of users. And we go through a therapeutic trial to have them funded, and then continuous funding based on showing efficacy.
Dilini, thank you for your talk. And in Europe, the work you are doing would be called one of a whistleblower. So people identifying problems within a system and trying at least to take them to the surface, to make them visible. And it is important, right? I noticed anyway that compared to at least the reality where I come from, that patient associations are not so, developed, involved. Is it a problem of awareness, something to work on?
Very good question. It does take patient champions. And when I moved here, I wasn't actually looking at doing HHT. It was patients who were traveling back and forth to Toronto to get care. A colleague of mine there, Marie Fawnin, asked me to see a couple people with HHT here in Edmonton, which subsequently grown. So the patient group, I would say, had a bigger impact on development of the HHT center than us alone. We were seeing them, but we were seeing them in a discoordinated manner. With severe asthma and CSAN, I didn't go into that as much, but we have a very different sort of patient group who's engaged at not just the national level, at the international level. Our current CSAN patient lead in Manitoba, she works with different groups, raising asthma awareness, and not just severe asthma, but asthma and general awareness throughout Canada. She's a patient advisor, also with Canada Infoway. So their involvement is very different compared to the HHT patient group. The proportion who don't get engaged is much higher than those who do, and that's in any disease. You have a few people who are interested, active, and speak up when themselves or others they know are affected, and that helps a lot. I didn't go into, we had a issue with genetics, and in terms of how complicated it is to get molecular genetics done. In Alberta, actually more so than other provinces due to cost. But there's been a big change since last September, which has made for HHT at least much easier, as well as another patient group member spoke up during pregnancies because at that time they were not allowing cord blood sampling for testing of the baby. So because of that NF1, now we have cord blood testing for HHT as the norm. So it's very different now, and a lot of it's not direct patient care, it's the indirect involvement of patient groups.
So you see, if you want to really change things, you have to go to politicians, and the only ones who can go to politicians are the patients. So that's my answer. Yeah.
That's right. And one of the key things here in Alberta is we have a very different system than our neighboring provinces. So with the reliance on the oil and gas industry, we see these big booms and the big busts. There's actually a book published on that, the Boom and Bust Society of Alberta. But that affects healthcare delivery and sustainability modeling too. So whether it's ILD, as you work in HHT, asthma, but us as physicians, what we can do is look at what's the best model in Alberta. And, you know, there's no one answer to last a lifetime. It changes over time. But that's reducing healthcare costs. So there's a few people who are joined here and on the panelist group. If you so wish, please feel free to open your cameras, Ellen or Anne, or there you go. And thanks again for all your help in this journey. Thanks, Bob. Thanks, Ellen.
Thank you very much, Dilini. And please, for the participants, also remember to vote for the faculty evaluation committee. It is very important. The link is again in the chat box. Thank you. Thanks a lot.
Okay, take care.